this winter. It's great to have colleagues here from across the geography who've been able to join us in taking the opportunity to hear more about asthma and allergy. We plan to record this session with the intention of sharing it on our various platforms for other colleagues to be able to access at a later date. If I can ask you to move on, please, Jen. Great, thank you. It would be really, really helpful if colleagues in attendance could introduce themselves in the chat to give an indication of the organisation and the geography that they represent, as it helps us to give an overview of the reach of our session. And please also feel free to use the chat function throughout the session, as this is a great way to connect. In terms of who is in the room, we've got a wide range of participants in our audience from across our geography. We have a large proportion of individuals from health, and we've also got colleagues from the voluntary community sector and other organisations across the board. Next slide, please. I'll briefly introduce myself then. My name's Louise Dauncey. I'm the Network Delivery Manager for the Child Health and Wellbeing Network, and my main role and responsibility is around delivery of the Children and Young Persons Transformation Agenda, which focuses on the deliverables of the NHS long-term plan. Delighted to be here to welcome you to the event and to provide a whistle-stop tour of the network and to set the scene before handing to our chair for today. Next slide, please. The Child Health and Wellbeing Network team is made up of a number of colleagues working on a diverse range of interconnected programmes to improve health and other outcomes for children, young people and families. In terms of the evolution of the network, we've taken feedback from stakeholders and work on the delivery of projects to respond to the emerging needs across our local communities, working to deliver innovative and transformational change at pace by spreading good practice. Within our network, we've got a range of work, including youth voice, inequalities focus, including the Core 20, comms and engagement, as well as CYPT, the Children and Young Persons Transformation Programme. The network membership itself is a collection of representatives, currently standing at over 2,000 members. These individuals hail from across our broad system, including education, health and social care, as well as from across our local geography. I won't labour on the detail on this slide, but just to provide a bit of context, within the North East and North Cumbria, we have the largest ICS footprint and we have significant areas of deprivation. The takeaway here from this slide is that for the first time in 2020-2021, the North East overtook London for numbers of children living in relative poverty. As a professional working in this area, I'm sure that you'll be aware of the socioeconomic challenges locally and the impact on health and other outcomes on our children and young persons population. In reality, this means that in an average class school size of 30, statistically 11 of those children will be living in relative poverty. Next slide, please. We're acutely aware of the lifelong impact of the childhood environment on health inequalities and that they take root in early childhood. The Institute of Health Equity has published a report that describes this in detail and looks in detail at fuel poverty and cold homes and provides some interesting information that aligns with the Core 20 framework. There's a link here on the slide for you to be able to look at this at your leisure. Next slide, please. Historically, in terms of our development and identification of priorities, stakeholder engagement was undertaken in 2018 and 2019 with over 1,000 points of contact from across the system, including education, health, social care and voluntary community sector. And this also included engagement with children, young people and families. From this came our mandate, which was about connection, sharing good practice and driving improvement. Next slide, please. The Child Health and Wellbeing Network focuses on the needs of children and young people, and as such, children are at the heart of everything that we do. Initial stakeholder engagement with the network was established historically and has given us a range of priorities. I won't go into detail here, but for those colleagues who are living and working in our local geography, none of these areas of priority will be a surprise, given our known levels of deprivation. We've identified a series of enablers and cross-cutting themes, and you'll see here that using all settings is highlighted within here as one of these themes. And within this, we have a growing role in relation to the Children and Young Persons Transformation Programme, particularly in relation to additional needs and vulnerability and childhood illness. Next slide, please. Again, I won't go into detail as time is short. This slide just provides local context around the children and young persons population and also gives an indication of the size of our geography. The map on the right also marks out the 13 local education authority boundary areas that we cover, including 13 local authorities, 13 public health authorities, 8 acute trusts, 2 mental health trusts, 3 ambulance trusts, as well as numerous primary care networks. Next slide, please. Our network is growing and has a broad representation from across the system and children's workforce. The visualisation here provides a breakdown of our membership, and as you can see here, we currently stand at over 2,000 members. Within our fold and wider team, we also have an apprentice. His name's Adam. He's supported by Head Starters in Middlesbrough, and he's become really engaged in our work and provides us with expert input into our professional groups and youth boards. He brings knowledge and lived experience and has a keen interest in looked after children and care leavers. Next slide, please. I won't spend too much time on this slide, but this just gives a flavour of the various projects and programmes that we've undertaken or are currently in progress. And this demonstrates the various mechanisms and partnerships that are in place to embed these connections and to share good practice. Next slide, please. This slide here provides a link for colleagues and partners to review the North East North Cumbria Facts of Life. This pulls together a range of publicly available information from public health fingertips and provides some helpful data and evidence-based research to be able to provide information about the levels of deprivation and our local socioeconomic challenges. Next slide, please. Information is available here about one of our particular programmes, particularly prevalent to this subject area. It's about respiratory illness, and collaborative work has been undertaken to identify available resources to support professionals and individuals alike. All of our information is hosted on Healthier Together, and the links are available on these slides. Next slide, please. So in relation to the Children and Young Persons Transformation Programme, then it has three main aims in relation to the integration of services, improving the quality of care, outcomes and experience for children, young people and their families, and the more ready and active involvement of children, young people and families in service design and development. All of this aligns to the vision of the Child Health and Wellbeing Network and our identified priorities. Within the Children and Young Persons Transformation Programme, there are 10 key strands of work and long-term conditions are identified as a priority. Next slide, please. In terms of work that we've delivered as a network, this just provides an overview. We've undertaken delivery of specific NHS England programmes for children. We've undertaken a range of partnership bids, for example, tackling inequalities for children. We've gained broad input from across the system and geography to build our membership, and we have now over 2,000 members. We share good practice and have enabled spread, for example, poverty proofing, STAR and youth mental health first aid. And we undertake a range of regular communication activities, including huddles and other such forms of engagement. Next slide, please. So finally, this provides us some food for thought about the network and our underpinning aim. We work hard to advocate for children and their families, and this is our moral and professional duty. This here on the slide is a quote from Sir Al Ainsley Green, and this has become our day-to-day way of work and moral compass. So without further ado, I'll hand over to Dr. Samantha Moss, who will now chair the session. Dr. Moss is the clinical lead in the North East and North Cumbria for the asthma programme and is a consultant respiratory paediatrician for Great North Children's Hospital. She leads the delivery of the regional severe asthma service. Dr. Moss comes with a wealth of experience in this clinical area and is passionate about cross-sector collaboration to improve outcomes for children and young people in the North East. Many thanks, and over to you, Sam.
Lovely, thank you, Louise. So hopefully you've all seen the programme. We've got a programme today which will go through a little bit of the background of asthma and asthma triggers to give you some more insight, then focus on some of the work that's been done in the North Eastern Cumbria with asthma in schools, and then some of our anaphylaxis work and aspirations as well. So without further ado, I'd like to introduce our first speaker, who's Carol Barwick. She's a children's specialist nurse down in Middlesbrough, and she's one of our community asthma advisors for the region.
Thank you, Sam. Next slide, please. We're just talking this morning within the Huddle on the importance of asthma. Next slide, please. The Huddle sessions were divided into 4 sections, talking about what's asthma and treatments, asthma management and triggers, and we're going to introduce our Asthma Friendly Schools accreditation and also our sports and activities. And session 4 will be about anaphylaxis. Next slide, please. Session 1 on the importance of asthma and statistics, what is asthma and the treatment for asthma. Next slide, please. The importance of asthma is that we now have 5.4 million people who suffer from asthma in the UK, 1.1 million of these being children. It's a common and chronic disease, and we do know that the outcomes for children in the UK are amongst the worst in the West. and also the outcomes for asthma are worse in the north of England. Next slide, please. What we know already is there's significant reports and guidance on the serious and concerning outcomes relating to deaths for children and young people with asthma. Despite raised concerns in NRAD, National Review of Asthma Deaths, in 2013, the main findings were that in a very high percentage of these children, their deaths were avoidable. And what remains concerning is that the rate of asthma deaths in these young people have remained constant from the years since the report was published. Next slide, please. As you can see from this slide, asthma admission rates have varied with the reduction during lockdown and the pandemic and with social shielding. However, they've risen significantly since recovery, and the September peak, as you can see, is still present in all years. Next slide, please. In September 21, the National Bundle of Care was presented to us in order to address the concerns regarding the frequency of admission, morbidity and mortality relating to children and young people with asthma. NHS England and NHS Improvement's ambition is to reduce avoidable harm to children and young people with asthma and improve their quality of life. This will be achieved by taking a whole system approach to asthma management. Organisation of care and leadership. The expectation is that integrated care systems should have a named lead with asthma expertise who is responsible and accountable for the dissemination and implementation of asthma standards and good asthma practice. In terms of environmental impacts, all professionals should understand the dangers of air pollution, both with indoor air quality and parental smoking, and ensure that they both discuss these risks with children and young people and families, but also address this within their settings. In terms of early and accurate diagnosis, this should be based upon clinical features of a comprehensive history. Diagnosis should be recorded and coded accordingly. An awareness of signs of asthma and communication with parents is important within other settings, particularly educational settings. With effective and preventative medicine, all children should have a personalised asthma management plan. Prescription of inhalers should be appropriate and education given regarding the use of their inhaler. And regular reviews should be undertaken. One of the main focuses is managing exacerbation. There are national standards and recommendations in terms of management and pathways and managing exacerbations of children. Each ICS should ensure that children and young people with severe asthma should have access to treatment, to a service for difficult to manage asthma. In terms of training and education, everyone working closely with children and young people should be trained to the appropriate level to ensure that there's a recognition of symptoms, management of symptoms, and referral to appropriate health professionals where necessary. There are several tiers of training and education available on early learning for health, and my colleague will be talking about these later on in the presentation. NHS data should be shared and used more efficiently, and this can help identify variations in care, prescribing and monitoring any changes that are implemented. This includes better use of remote consultations and asthma apps, making it easy for people to attend appointments and self-manage effectively. And in-school databases can identify these children with poor attendance and may be utilised to prompt parents to attend for an asthma review. Next slide, please. So what is asthma? Asthma is a common lung condition that causes breathing difficulties. It affects people of all ages and can often start in childhood. Several conditions can cause similar symptoms, so it's very important that the proper diagnosis and correct treatment is given. Next slide, please. The tracheobronchial tree has branching structures of approximately 23 branches or generations, extending from the trachea to the last order of terminal bronchioles. The airways are tubes that carry air in and out of the lungs. If you have asthma, the airways become inflamed and narrowed at times, and this makes it harder for air to flow through the airways and breathing out, particularly with asthma. Next slide, please. The diagnosis of asthma is made on a careful review of past medical history and family history and physical examination. It's based on a pattern over time of certain presenting signs and symptoms. And we know that asthma can improve and deteriorate over long and short periods of time. Additional tests and investigations which may be useful are things like lung function and pheno testing, which are based upon blowing tests, and they can be performed within clinic. And sometimes children are monitored at home with peak flow monitors to engage the family in the care of their child, and also to ascertain the changes in their asthma management throughout a pattern of weeks or throughout the day. Often the diagnosis of asthma is made following a trial of asthma treatment. Next slide, please. So when we suspect a diagnosis of asthma has common symptoms in presentation, but not always the same in each child. Wheeze cannot always be heard, and cough can be variable depending on the trigger, particularly if the child has an infection. It's very common to see coughing, wheezing, and breathlessness in children. And wheeze can always be heard, and often it can be heard only through professional examination with a stethoscope. Next slide, please. Emphasis on the importance of treatment and knowing what a child should be taking and how the inhaler should be taken is very important. Treatment can be increased or decreased according to symptoms, and the correct inhaler technique can make such a big difference to a child or young person's response to treatment, both long-term and in the case of an attack. There are many different forms of medication that children may take. An exacerbation of asthma or an attack may require oral steroids. Children with very severe and difficult asthma may even need to have injections regularly in hospital, or in some cases, self-manage this by delivery at home. It's very important for all healthcare professionals and everyone who comes into contact with a child and young person, understanding which treatment the child is on, how the inhaler does that job, the best way to give that inhaler, and recognition of signs and symptoms that a child's health is deteriorating, and when to seek medical care. Next slide, please. Asthma can be well managed for the majority of children and young people, and the aim of the treatment is to reduce weekly symptoms, reduce the needs for oral steroids, ensure good concordance with treatment, encourage a good technique, and supporting the family and the young person by educating and empowering them to self-medicate and self-monitor. Knowing which is good control will prompt early recognition of intervention needed. This is an example of the different types of treatment, and you can see here how asthma can become quite complex and complicated for families in terms of the number of different inhalers that there are available. Many children come to clinics who have different inhalers and are not quite sure how they use their inhalers. So we have these resources to ensure families within clinical settings and other settings can identify which inhalers they've been given, which they've used in the past, and also for us to help identify which one the child would be prepared to use. Next slide, please. There are different types of spacers. We do now recommend that all children who have a gas-propelled inhaler or a meter-dosed inhaler uses a spacer device, even if they're older children, and particularly during sport. Next slide, please. Moving on to session 2, we're going to talk about the triggers for asthma, how to recognise an asthma attack, and how to manage an asthma attack. Next slide, please. Triggers. There can be triggers for children which are common, including infections, weather changes, smoke and pollution, which we've already spoken about, allergies such as pollen, house dust mite, animal dander. Some children have sensitivities to medication, particularly aspirin and brufen type medication, but this isn't true for all children. It can be specific cases. There are emotional changes for asthma, including stress. Some children get wheezy when they laugh or when they get anxious. And we know that mold and damp home environments can specifically trigger asthma symptoms. And we know it's very common that children with asthma struggle to do exercise and activity, and particularly those activities requiring stamina or those in cold weather, those held outside. Next slide, please. There are some common triggers within school. Some schools still have some pets in place, and particularly strong smells from glues, paints, etc. We know that there's house dust mites in carpet and soft furnishing, and a lot of schools have worked hard in the region to remove these soft furnishings in order to reduce the exposure. Some of our older schools and buildings, and some of our buildings that our children are exposed to for out of school activities, have damp, moisture and mould. At this particular time of year, when the leaves have fallen, we know that moulds gather on these leaves and the mould spore count is higher in September and October. Freshly cut grass is a common trigger, and we know that schools cut their grass in the middle of the week occasionally, and we have addressed that in some of our work that we've been doing with local schools. And that some of our schools have responded by now arranging to have the grass cut in the latter half of the week, or a Friday, or even at the weekend. We know that cleaning products, sprays, aerosols are all triggers to asthma, and commonly this is occurring within the home. I find particularly children who have elder siblings are the last one to get into the bathroom in the morning, particularly exposed to the very strong and pungent smells that occur with older children spraying their links or whatever. In terms of exhaust fumes, we know that children's walk to school, there can be a high exposure of pollution, and we are suggesting that if there's an alternative route to walk to school, or an alternative route when they're out with families, that they don't walk their children along main roads. We know that particularly in the summer holidays, repair work and maintenance work goes on within schools, so that when children return in September, they are exposed to dust and strong smells of paint. Next slide, please. This is one of the resources that was developed in response to our schools' feedback. They asked, could they have a calendar in terms of messages that they could send out to patients on social media and platforms. And that was to include different times of the year and different occasions where their child's asthma may be triggered. This, interestingly, in the winter, we were looking at triggers and looking at particularly this time of year. Within clinic, we have discussions where we talk about when Christmas decorations come out of lofts and they're dusty, and also talking about when real trees are brought into the home, and they may also trigger an allergic response. Next slide, please. This is also an example of a very useful resource hosted on Beat Asthma, which talks about the recognition of an asthma attack in all circumstances and in all settings. It points towards looking at things like breathing hard and fast, whether a child is wheezing, what sort of cough the child has and whether that cough is getting worse. It talks about looking for breathlessness. And also children describe their asthma in very many different ways. And younger children can talk about tummy ache instead of chest tightness. Our older children describe the symptoms very much better, but it's something to be recognised and be aware of. And one of the most important factors is the increased use of reliever inhaler. When a child has a rescue or relief inhaler with them, the good management of asthma would be a child would only use their blue inhaler less than 3 days out of every week. So it's important to know that a child using more blue inhaler, that it's a significant sign that their asthma is not well controlled. Next slide, please. One of the other resources on Beat Asthma is about the management of a child or young person. It's a busy slide, it's been broken up here, but it shows two elements or strands of the assessment in terms of mild to moderate symptoms, what we'd be looking for, and what we would be looking for in a more severe or life-threatening episode. Next slide, please. On this particular pathway, it talks about how to respond, what the treatment would be for a child who has an exacerbation of asthma, the administration of medication, how much of that medication to give, and what the period of time would be to observe that child or young person after an exacerbation of their asthma. On the right-hand side, you can see that the more severe and difficult episode would be managed in a different way, with more medication being given, and there is direction into when you would phone an ambulance. Next slide, please. Certainly the most important thing is the child or young person responding. On the red side of the action plan, the child will have already been referred to hospital. On the mild to moderate side of the plan, it talks about allowing the child to sit for 15 to 20 minutes, allow the child to return to class, but most importantly, if symptoms reoccur after 4 hours, to repeat and ask the parents to collect the child. Next slide, please. So we've already talked about children having personalised asthma action plans. Asthma plans are very, very important in terms of it's important to take prescribed asthma medication every day and to prevent symptoms and reduce the risk of an attack. The plan identifies what to do if symptoms get worse. There's information about emergency and when to call 999. Asthma action plans have been completed by a healthcare professional, so they are specific to that child. They're presenting symptoms and the action needed. A plan can also be used to support the child and young person so that their friends are aware of what to look out for, and also education staff. And they also help keep routines, especially during school holidays. Next slide, please. This is an example of an asthma management plan. This one is taken from our Beat Asthma website. It's a really useful plan. It's divided into sections. Next slide, please. It talks about when asthma is good and what treatment the child should be taking. It talks about when there is a warning that there's some deterioration or change in the presentation of asthma. And it also talks about when we should be more concerned about a child's asthma and their presentation and what actions to take at each stage. Next slide, please. This is another example of an asthma management plan that's around in the community, and it has got a very similar content and can be adapted to the child's specific needs. Next slide, please. And the next slide, please. Okay, and I'll hand you over to Claire Cagle, my colleague, who's going to talk about primary care settings, secondary care priorities, and schools and clubs accreditation. Thank you, Claire.
Thank you, Carol. Claire's also one of our community asthma advisors, and her background is a public health specialist nurse in the 0 to 19 service.
Thank you, Sam. Yeah, so we're going to continue looking at primary and secondary care priorities, introduce the Beat Asthma Friendly Schools and the sports and activities accreditation, along with the training that is available. I'm not going to go into detail regarding the bundle of care because obviously Carol's discussed that in detail. What we have tried to do is incorporate the bundle of care into the schools Beat Asthma Friendly Schools Award accreditation and the sports accreditation, and some of these elements are included within it, and we'll discuss that later in the presentation. Next slide, please. So looking at primary care, this is some of the work that's been undertaken to tackle primary care, and it's a huge piece of the project and the work that we've been undertaking. We've developed resources and research with lots of references available for people to utilise to enhance their asthma knowledge when working with children and young people. We've presented to a number of TTOs and primary care nurse network meetings across the whole of the area of the North East and North Cumbria, presenting the national care, the bundle of care to GPs, practice nurses. We've also been involved in our PANIC, which is a regional asthma meeting, and we're also involved in the NetPAC conference for our area. We've undertaken webinars and podcasts, that's for practice nurses, and we've also just undertaken one for schools and education. There's been a mapping exercise and surveys, questionnaires that were sent out January 2022, and those results were taken on board and provided to the primary care of areas that needed to be improved and areas that could be worked on in practice. We've spoken to parent carer forums and children and young people to get their views on asthma. And we've also produced some pathways and guidance so that we've got uniformity across the whole of the North East and North Cumbria area. Next slide, please. So secondary care, again, there's been the resources and references produced. There's also been pathways and guidance and letters for education, templates that are there just for schools to print off if they have concerns about a child or young person who may have asthma or who may be showing signs of asthma, that schools can just print off and sign and send to the parent. We've also worked with secondary care settings. There's a meeting arranged to support the secondary care nurses. That's coming up in the new year, to look at how they're working across the North East and North Cumbria and look at what's been undertaken in each area and what support can be offered. We have again the PANIC and the NEPAC conference. And again, there was questionnaires undertaken with our regional trusts to look at what work was being undertaken prior to the project being started. Next slide, please. Schools, again, this has been an area that has really taken off and led to the development of the BEAT Asthma Friendly Schools accreditation, along with the schools policy. Again, we've got the letters for the schools that we've discussed, and these are all available on our Healthier Together website. The pilot project for the BEAT Asthma Friendly Schools is now being rolled out across the North East and North Cumbria to 1,440 schools, and the schools are slowly coming forward and wanting to become involved with our Asthma Friendly Schools accreditation. Again, schools are invited, and some of our pilot schools attended our NEPAC conference, which was lovely to see. That multi-agency working and networking across all agencies, health and education. We've got our accreditation. The primary schools pilot has now been completed and is being rolled out, and there's a number of secondary schools enrolled to pilot the project. Following the BEAT Asthma Friendly Schools, schools had asked if they could have an assembly undertake. So the schools that were as part of the pilot, we undertook an assembly, and this was part of they wanted some more information about asthma, but simple information that could be provided to the children. So 2 assemblies have been produced for primary and for secondary and colleges, but they're interactive assemblies with videos and an opportunity to ask questions, and these were presented as part of the celebration of the BEAT Asthma Friendly Schools accreditation being achieved. And last week we were lucky enough to work with Schools North East and present a schools webinar across the whole of the North East area for the schools, and they were obviously invited to that session. Next slide, please. So this is an example of our 9 steps accreditation for the BEAT Asthma Friendly Schools. It builds on the work already being undertaken and the good practice within schools. So we're looking at that they have the schools, medicines for schools, information within schools, so how to support children and young people. Also, the emergency asthma inhaler information within school. This may be printed out in school, or it may be they're able to access it online or on their shared drives within the school. We also have an asthma monitor. So we're monitoring asthma attendances. We know that parents will often ring in and say that children are off, and it's closed down as an authorised absence because they have a diagnosis of asthma. So it's encouraging schools to monitor that, so that we know if these children are off frequently, that this is maybe questioned, that there's an asthma register in school. This isn't necessarily just an asthma register, because what we have said to schools is they already have a register within schools that incorporates medical conditions. So what we're hoping is that schools have identified on that register, because we don't want them having 2 or 3 registers, so not all staff can access it, but they've got that register, and it's key that those children with asthma, it's highlighted with on there. We're looking at the school having a named lead or champion. If it's a secondary school, we're recommending that they may have 2 or 3 leads, and that they have a healthcare plan or a personalised asthma action plan in school for those children and young people. It's knowing about the emergency salbutamol inhaler kit. It talks about what would be included in that kit and what would be needed, and the expectations. So our primary schools, our smaller ones, may have 2. kits in case schools go on a school trip and one goes out of school. Some of our bigger secondaries or schools that are on split sites may have 3 or 4 kits. And we talk to the schools about making sure that they look for around for the costing of that, because we have had a variation from anything between a cost of £10 for an inhaler and a spacer to £40. Medications, that parents provide the medication and it's stored in a safe place, and there's a system to check expiry dates. This needs to come into school with the labelled prescribing details on. We're also looking at self-management of children and young people. So we're looking at the year 5, year 6, so key stage 2, that the children may be able to take their own inhaler and then let the teacher know, just so that when they go to secondary, when they've got to carry their inhaler at all times with them, they're getting used to that in the primary school, and that they're not having to go to an office or walk quite a distance to have their inhaler. So if parents and teachers and the children and young person is able to do that, we are encouraging that. Looking at the bundle of care for the pollution, obviously what we're looking at is triggers for indoor and outdoor pollution. Carol's already mentioned this. So it's things, when is the grass cut within school? Have you got a smoke-free and a vape-free policy in place? Do you have staggered drop-off times? Some of our schools where there was a lot of education transport, what they'd incorporated was actually the buses turning off their engines during pickup time until the children were all on the bus, and then restarting their engines to reduce the pollution. Are the children playing right next to a main road, or is there an area within school that the children can play which is set back from the main road? We're looking at the whole school approach and how parents are involved. So some schools will have apps and dojos, and some schools use social media. So how we send those key messages out, particularly the calendar that Carol talked about, we can send that out as key messages. Remember, it's Christmas coming up, or bonfire night. Please ensure that your child has their inhaler. Some of the schools looked at having asthma ambassadors, so these would take on assemblies, or they may educate other children about their asthma. In secondary schools, what we suggested, that they may have a medical board that they put up information around asthma and how to support your friend if they're having an asthma attack. Some of the schools even took on a parent governor who was responsible for medication and looking at asthma and making sure that everybody was aware of the policy and any changes that were available. And we've also got staff training, which is free online training. This is available to all staff, and I will discuss that a little bit later in detail. But for the accreditation, what we're hoping is that 85% of staff would be trained, and this is staff. What we have talked about is in the secondary schools there may be over 200 staff, so looking at those staff who are the key staff who have contact with the children, and we'd like 85% of them to undertake the staff training, and this is every other year, the training. And then moving on from the pilot, we now have the accreditation process on Healthier Together, where schools can start to work through the information, the accreditation, and when they feel ready, they can book a slot at a validation hub. And we have these dates set for December, January, and February and March, and the schools will be able to come and provide their evidence of how they've achieved the accreditation, and the community asthma advisors would either give them some actions, or if the school's been successful, they would then be accredited. Next slide, please. This is an example of the skills policy. This has been available on Healthier Together for quite a period of time now. This just shows the content of the policy and what's included within it. Schools can literally just print the policy off and add their name and their asthma lead to the front page. There is lots of resources available at the back that they can print themselves and put up within schools. And we know, I think up to October, we'd had the policy downloaded 590 times. That's really positive. Next slide, please. This is just some photos of our presentations of our lovely schools that achieved their Asthma Friendly Schools Awards in May, June and July of last year. and some of the children, and obviously there's the little girl at the bottom there with the winning logo which presented. So within the schools we either went and presented the award, or we presented an assembly to the whole school, which was really nice, and schools really enjoyed the celebration events. We know from the pilot project group that we've had some really positive feedback. 92% of schools reported an increase in confidence in managing of asthma of children and young people with suspected asthma or a diagnosis of asthma. 100% gave positive feedback around the accreditation, the resources, and approximately 30 examples of good practice were shared, or changes in practice that were made within the school to improve the asthma care. And 42% of the schools reported a reduction in school days lost due to asthma. Next slide, please. Moving on to our sports accreditation, this is a new pilot that's due to be undertaken. And again, there's resources available on Healthier Together. We're promoting the National Bundle of Care. We're looking at developing a sports webinar for early 2024 for sports and activity clubs. And we're also in the process of making contact with some clubs and activities who may want to engage in the Beat Asthma Friendly Schools and sports accreditation. Next slide, please. This just shows our Beat Asthma Friendly Sports and Activity accreditation. Again, it's similar to the schools, but obviously a lot simpler what is required. We're still looking to incorporate the pollution and ensure that there's an asthma register and a champion. And rather than a policy, we've got an inclusive statement to ensure that all children and young people can take part, whether they have asthma or not, and that they're included. And again, we're looking at the training to be completed. This would depend, we'll discuss this with individual clubs, because some clubs may have lots of leaders or activity leaders. Other clubs may only have one or two. So we will discuss that individually with the clubs when it comes to accreditation. Next slide, please. Looking at the training. So for education and sports clubs, we're looking at a tier 1 training. There's 5 tiers. Tier 1, 2 and 3 are free training. So tier 1 would be for the schools, our sports, social care, after school club leaders, children's centre support staff. It's a 45-minute online session with multiple choice questions at the end, just to check people's understanding of the training. We are in talks at the moment to look whether this may be able to offer for particularly schools or our larger secondary schools, whether it can be undertaken as a bulk training session or a group training session, and we will notify schools as soon as we have that clarified whether that would be available to undertake. Tier 2 is for our school nurses and health visitors and any practice nurses who may be involved in asthma or asthma reviews. And tier 3 moves on to people who may be assessing and prescribing asthma medication for children and young people. Next slide, please. And this is just an example of our tier 4 and 5. And tier 5 is for our tertiary centre staff. And that is available. Obviously, tier 4 and tier 5, there is a charge for. Next slide, please. And this is just an example of some of the resources that have been used or that we've found useful for staff and people. We've also got our Healthier Together, which has lots of resources on there, not just asthma, but lots of other medical conditions. And we also have our Beat Asthma and Beat Anaphylaxis website, which are really useful because they have sections for children and young people, for schools and for health professionals. And there's lots of videos on both of those websites that can support your care for children and young people with asthma. Thank you very much.
Thank you, Claire. Can I just remind everybody that if there's any questions or comments, if you put them in the chat, and then we can use that to help inform our discussion after the break. So our final presentation of the morning is from Dr. Andrew Bright. He's a consultant paediatrician in Gateshead. He's editor of the Beat Anaphylaxis website, and again is part of our advisory group. Thank you, Andrew.
Yeah, nice. shout if you... So thanks very much for inviting me to do a short presentation today. 10 minutes, goodness, that's a short spot, so I'm going to race through, but try and focus on the really important things as I think we see them in the asthma leadership group. So as Sam says, I work in Gateshead, but also work at Great North Children's in Newcastle, doing some allergy work as well as general paediatrics south of the water. So I'm going to take you through paediatric anaphylaxis. A couple of quick declarations there. I sit on a national committee and also done some public-facing awareness campaign, which was remunerated. I'm also the co-chair of MPAG, which is the Northern Paediatric Allergy Group. So, agenda for this short presentation. I'm going to tell you about a young lady, and really it's kind of an explanation about why this is such an important issue and why we're working and fighting so hard for raising awareness for anaphylaxis, improving its management. Talk to you very briefly about what anaphylaxis is. Again, I could speak for hours on the topic, but give you a kind of a bite-size summary of what it is, and indeed talk about the big problems really with anaphylaxis and why it's such a challenging condition to manage, not just in hospitals, but throughout our communities. Talk to you a bit about one of my favourite topics, beat anaphylaxis, and then I'll do a brief summary, and then there'll be discussions, I believe, kind of following the 4 presentations. So, can everyone hear the audio on this? It should come in about now. Do shout if you don't, I've got a backup.
I can't hear the audio, Andrew.
Okay. I anticipated that, so we will switch over to we'll just switch over to this version. So this should work now.
Still no audio on that, Andrew.
Really? Right.
Have you shared your computer sound when you've shared the screen? You've got to toggle the little setting on the sharing.
Go to the share again. Include computer sound. That will be the one.
That's the one, yeah.
Thank you for the for the help with that. Let's try. Is that coming through this slideshow?
I can't hear anything. I can see it, but I can't hear.
I'm not able to view the slideshow now, which is rather frustrating. Right, apologies for this. 2 seconds. I think I've fixed it. Is there any audio? It's just going to stop there.
Yeah.
I think for me,
Yeah.
she was always a people person.
She was always kind and helpful towards people all the time, wasn't she? Yeah, she loved making people happy.
I was always vigilant about ingredients and things and watching out for those elements that had caused issues in the past.
Ellen was also
Ellen
was very good good managing that, what she was eating,
She
wasn't
was,
she?
she
She was
was.
very good.
She came down saying she wasn't feeling very well, so she was going to have something to eat. And she made herself some cheese on toast and went back upstairs. And then about 5 minutes later, I heard her shouting, so I went up to the stairs and she was kind of on the half landing with her spacer and an inhaler. And I don't know, I just said to her, do you need an ambulance? And she just said yes.
Ellen, even though I don't think she was panicking, but she knew something was wrong. She came down, sat in front of us on the bottom of the stairs. She put a hand on my knee and she said it was, Daddy, please don't let us die. And I said back to her, don't worry, Ellen, you won't. She squeezed me leg twice. And she turned blue, slumped over. And obviously I was in a panic, I didn't know what to do. I dealt handed the phone from the emergency services, and they took a lie out flat on the floor and do chest compressions, which I did. It was incredibly stressful. And I always thought I was quite a calm person and good in situations and didn't panic. And honestly, I did. That's the thing. As a father, I felt helpless. Within seconds, just watched the colour drain out of her face.
You just know immediately. And they just said that she'd had a heart attack and that they couldn't.
So me and Mum saw on the stairs, we just thought it was asthma, didn't we? That's all we thought it was.
We just thought it was the same, and it wasn't the same. I think it was really important to support anything that raises awareness of anaphylaxis. Asthma wasn't a direct cause of Ellen's death, and it was anaphylactic shock through eating some, we think, some crisps with crustaceans on, which I assume was probably on the flavouring.
She did have allergic reactions to certain foods now and again, but it was always minor, wasn't it?
Yeah, but you don't make that link, do you,
No.
between allergies, asthma and anaphylaxis. And for me, there is a link. Her body couldn't fight the anaphylaxis reaction because she was already asthmatic as well.
It just shows she made one little mistake. She didn't make you say her guard was down or whatever. She just had something that you wouldn't normally have.
It's incredibly important, and you don't know how important it is until you lose your child. And I don't want anybody else to have to go through what I go through every single day. Like, it isn't just that day, the first year, it's forever. It's forever. When Ellen went to the asthma checkups, I think it would have been helpful to have something there, sort of raising that awareness of anaphylaxis and maybe the allergies and I think for me are kind of like the 3 A's, allergies, asthma and anaphylaxis. Or I suppose in a way bedfellows, they're connected. They're not necessarily always all connected, but 1, 2, 3 of those things. I think doctors will understand it, but perhaps not link the allergy, asthma, anaphylaxis thing together. So joining those dots that actually these 3 things do go hand in hand. It's really, really difficult to say how difficult life just is. Anybody who comes into contact with somebody that has, allergies or asthma, it could be a candidate for anaphylaxis. Just please take notice of them. I mean, I will miss my child for the rest of his life. Until the day I die. There is another website called Beat Asthma. So both Beat Asthma and Beat Anaphylaxis will give you loads of information about those conditions in an easy to read format. There'll be some stories from parents and things like that which will talk about it in a way that we really understand. I would encourage parents, educational professionals, doctors, anybody, family and friends of someone who's got asthma, allergies, to go on and have a look at that information.
So, thanks for paying attention and watching that sad story. But I think it's a really good way to start to really impress upon you the importance of anaphylaxis and the impact it can have. So, who was Ellen? She was a 16-year-old girl. She had a background of well-controlled asthma. She had aspirations and hopes like all young people do. But tragically, she passed away in 2019 to an anaphylactic reaction to a food she'd eaten, as the coroner put it. Now, this young lady had previous reactions to nuts in early childhood and been to an allergy specialist centre and had testing for nuts, fish and shellfish, which were all positive. And she was most importantly from Blyth, so one of our local communities, one of our local allergy services, and really a regular example of a normal family we could meet or in our own communities. So let's move on to anaphylaxis. What is it? The definition is that it's a serious, potentially life-threatening, generalized or systemic allergic reaction. It's usually rapidly progressing, so the symptoms come on very quickly and can deteriorate quite quickly. And it involves, the key is that it involves sudden onset of life-threatening airway and or breathing and or circulation or conscious level impairment, which is life-threatening. And it's important to know that can happen with or without skin changes, so with or without the swelling or the hives-like rash that maybe all of us think about when we think of an allergic reaction. Now, it usually happens in response to exposure to trigger, but not always as well. We call those triggers allergens. The mainstay of treatment, and this is something that really needs banging on the drum repeatedly, I think, across our nation, is that the mainstay is early treatment with intramuscular adrenaline injection. And I put on there just some of the subtleties about anaphylaxis, and this is taken from the allergy action plans that many of you across your different professions will come in contact with, especially in your education or healthcare. And those are some of the subtle symptoms below each of those kind of areas of airway, breathing and consciousness or circulation. So what's the problem with anaphylaxis, apart from it being life-threatening? Well, the problem is really that it doesn't happen that often. It's a low-frequency event. And, we've got some regional data on that. So in 2019, we did an audit across the 7 NHS trusts in the North East. We found that year there were 76 cases of anaphylaxis treated in hospital. The 77th was Ellen Raffle, who sadly passed away. Then we repeated that audit, and we're in a 2-year audit cycle, and we've included North Cumbria in the 2021 iteration, so eight NHS trusts, and that means that across our region, on average, around 90 cases, 93 that year. And again, looking at the child death review data, we see that there was 1 child mortality that year as well. On average, we're seeing about 1 death per year in our region from this condition. It's estimated that 1 in 300 of us will experience anaphylaxis at some point in our life. So, that's not that uncommon, and the incidence is certainly increasing for allergies and in turn anaphylaxis. Anaphylaxis is not recognized very easily. It's not always that clear to identify anaphylaxis, in contrast to, say, something like a severe acute asthma attack. And we've got data, across trained people, across healthcare professionals in both 2020 and 2022. We've done some survey work which shows that recognition is poor. And there's also a really heavy burden of things that we need to do after an anaphylaxis to prepare the child and the family and keep them safe. And that's just a kind of an example of how many things that need to be addressed. So I'll talk to you about anaphylaxis, beat anaphylaxis, and the website that has been developed by a wide-ranging team of professionals across our region. This is the website homepage. You might already be familiar with it. There's a URL and there's a QR code you can scan from your screen to have a look at it. It's basically a jump-off website, a resource-rich website, so that either there's bespoke resources that we've created, or there are links to very good already existing national websites. We've also got specific areas for healthcare professionals, both in primary and secondary care. Specific area for educators in schools and early years settings. We've got links to the adrenaline pen manufacturer websites with great videos on training and how to use them. And we've also got, and probably the strength of the website is a patient and families area with really bespoke targeted resources for children and young people and their wider families. We've got some education packages for healthcare professionals, and we've got links to further training for professionals, and some interest stuff on the latest research in the region on anaphylaxis. So, in summary, luckily paediatric anaphylaxis is not that common, so I don't want you to be afraid that it's going to happen to you every day. You're going to be working with children and young people who are going to have it, but it can kill, so we all need to be tooled up and understand how to recognise it and what to do if the worst happens. Early recognition is really, really key, and prompt treatment is with intramuscular adrenaline. So, for instance, if it's a first episode of anaphylaxis, it's really important for 909 to be called, because paramedics are the ones that, if they know that there's a severe allergic reaction occurring, when you call 909, they'll be dispatched as highest priority, and they have this life-saving IM adrenaline. But also, those at risk of anaphylaxis, or those that have had anaphylaxis previously, often carry adrenaline auto-injectors, so it's about being familiar with how to use those. You can use beat anaphylaxis. That's why we created the website, and that can support children and young people, their families, but also educators and those working with children in other settings, as well as healthcare professionals across our region. Please, keep your eyes peeled for upcoming pilots in primary schools that we're working towards this and next academic year, really mirroring some of the great work that the asthma team has done as part of the Child Health and Wellbeing Network. Finally, if you're managing paediatric anaphylaxis or any sniff of that, think about beat anaphylaxis. You can Google it; it's top of the search engine. Also, you can bookmark the URL in case you're in a hurry. There's also a QR code which you can use, which is widely shared. And if you want to follow us on X, aka old Twitter, there's a QR just to get you on there. It's at beat anaphylaxis. Happy to take any questions, but I think we've got a wider session for questions. So thanks very much.
Yes.
Those are my references.
Thank you, Andrew. So we'll have a short break now we're a few minutes late. So if we aim to come back at 11:10, and then we can have the little discussion session for about half an hour, 40 minutes. Please do, if you want to, type any comments in the chat, and we can use that as a foundation, or we can just start afterwards. So 11:10 back here. Hi, hopefully we're all back from the coffee break now. So I think you'll agree that that was 4 really great presentations that just gave us a flavour of what's going on, really. I think it's very hard in such short presentations to do it, but I think everybody did a great job. And as Louise shared, we will be more than happy to share the slides so people can click on the resources. Now, does anybody have any questions they want to start with? If I start then, I think, Carol and Claire, what do you think the biggest challenges for schools are in terms of making children with asthma feel confident that their needs will be met?
No. I think within schools there are lots of challenges. I think one of the things that most of the school heads particularly were relating to us was that there's lots of pressures associated with lots of different things in school. So they have lots of guidance to follow, they've got standards to meet for all sorts of not only medical and health conditions but education standards. And I think the appreciation was more of the feeling was that when they engaged with us in terms of asthma, it's almost the feedback I felt was we didn't know that we didn't know. So at first there wasn't really an appreciation of what the challenges would be until there was an understanding of the severity and more or less an appreciation of asthma in itself after doing the training, and then realised that there was some issues to address within school. So I think when we spoke to the majority of schools prior to taking part in the pilot, I think they felt that there was a reasonably good job being done of engaging young people and the management of asthma within school. But I think following the training and the intervention with the meetings that we had over several months, I think then there was, right, we really do need to improve our, standards here. So I think raising awareness of asthma like we have been and encouraging schools to take part in the training even before consideration of taking part in the accreditation framework will raise that awareness. I think engaging children, I think the pressures are going to come more from secondary. When we've talked about secondary care settings and in the few that we have engaged with, I think younger children are more happy to take part in assemblies and do challenges and presentations and things. But I think it's going to be a more subtle challenge in terms of secondary care children to share the message, because older children aren't so keen to stand up and say, look, I've got asthma and I take an inhaler. Whereas younger children are very much engaged in the ambassadors, and they're doing environmental ambassadors, and there are all sorts of projects in primary and secondary care. So I think the challenges across the 2 age groups of children are significantly different to each other. But I think that looking at the primary school settings we've engaged with, it's not insurmountable. And I think once the understanding of what needs to be done and what can be done, and all the schools did, there were some very generic changes that were made in schools, but there was also some very specific changes made, which was very encouraging, and they have all been shared with each other. So that was really promising, and that is really they're all very enthusiastic.
And I just think that the training that they undertook, they really felt that they really benefited from increasing the knowledge and understanding. I think what they felt, like Carol said, is that maybe the asthma was not on the back burner, but they were concerned about diabetes and epilepsy and lots of different medical conditions, whereas asthma they thought they were managing. But actually when they undertook the training and looked at the accreditation, they realised actually they needed to increase the knowledge and understanding to improve the care for children and young people.
Yeah, brilliant. I think that's great, because I was going to ask about the difference with secondary schools. So Jen, do you think we could stop sharing the slides just so we can see everybody a bit more with the discussions. I guess the other thing is as well, it's that moving away from the, oh, it's just asthma, it's just their asthma type thing. Whereas I think, yes, because of epilepsy and diabetes aren't as common, they've almost got a bigger profile, haven't they? I don't know if anybody else wants to share some of the challenges they've come across. Louise, you've got your hand up.
Hi, thanks, Sam. No, it wasn't necessarily about sharing a challenge, but I just wanted to make that comment about, I think because we're saying that asthma is such a common condition, we're really trying to work with our partners to kind of increase community confidence and competence, whereas the other conditions that you've mentioned, epilepsy and diabetes, they're predominantly managed and supported within sort of specialist, secondary healthcare services. And I think because of the sheer population and numbers of children with asthma, and the fact that we're also talking about a cohort of undiagnosed asthma, or those people who might have suspected asthma, I just think it's really, really valuable in that it's just a comment really rather than a question.
Yeah. If I can just say that I agree with you, Sam, on it's only asthma, and I think previously doing work with schools, years ago, there was the question of, oh, he's only got asthma, and I've got loads of them in my class. And I think when we start doing the training, and they certainly talk about the number of admissions and the number of asthma deaths, I think then it's something that certainly NRAD and certainly all of the national guidance we have for asthma does say we don't talk about it enough. We don't talk about the fact that children can die. And I think even with the families in clinic, it's still a bit of a shock and a surprise when we talk about the outcomes for children and young people. Less commonly, thankfully, for each of us individually. But I think as clinicians, we probably all have experience or a memory of a young person who has died in the locality, which is really quite sad. And I think that's not appreciated by the public still. Or any expert or anyone coming into contact with children and young people, when we say that, it's still a bit of a shock to to hear that children do still die of asthma and that the numbers aren't really improving.
And I think looking at some of the pilot schools, they actually all didn't have emergency inhalers in place. So that was something that was really positive from undertaking the accreditation, that they realised they could purchase some emergency inhalers for schools because they've never had them previously. And these are quite big primary schools.
Yes.
Yeah, and I know Andrew's working on something similar with adrenaline auto-injectors, so that there's emergency ones available for anaphylaxis as well. Nilmani, did you want to come in there?
Yeah, I just wanted to say that I think the parents say in the video that, whilst it might be obvious for professionals about the links between asthma and food allergies, and it's not always obvious to other people. So I think just to remember that a lot of these children will have allergies. And as Andrew said, anaphylaxis is a low frequency event. It's rare for people to die, but unfortunately, it's a major outcome if we lose a young person, or any person of any age, really. So if you have, if you think that the child has an allergy, or you think the child has eaten anything that they shouldn't have, or this could be anaphylaxis, it's much better to give the adrenaline than not to give it. You're not going to do any harm by giving the adrenaline, but you might save the child life by giving it. What we do know in anaphylaxis is that a lot of the time when there have been deaths, it's because there's been a delay in administering adrenaline. And sometimes these young people will present like an asthma attack. They might just be wheezy. It's just kind of thinking about, both conditions, and that often they will go together.
Yeah. I think there's a comment in the chat there that you find young people and parents who are often dismissive of their asthma, and they often don't have their inhaler with them despite listening to the medical. I share your pain with this. The amount of children who come to clinic and we say, oh, I think you need some inhaler, and they say, oh, I've left it in the car, or it's in my school bag. And I think that's something really important. And I don't know what your role is, Gerard, but it might be something that we need to look at within, when we talk about the club's accreditation, on how to encourage, we want to be inclusive, and it's very much about making sure children with asthma don't miss out because of their asthma. But maybe, we do need to have something like in your kit with your football boots, you should have, or your swimming goggles or whatever, you should have your inhaler, and make that the norm. I don't know, Gerard, if you feel, you want to add anything to that, or?
Yeah, I'm just to tell you my role. I'm a youth worker, and we work with young people outdoors, and so a lot of the activities that we do are quite active. And there's times when you get the situation where the young people will do a little bit, and then they'll stop and say, "I can't because my asthma." And I say, "Well, have you got your inhaler?" I said, "No, I haven't got my inhaler. I don't normally use it." I go, well, why? If you've got asthma, you should have it, sort of thing. So there's that kind of frustrations that we have, and say that parents rarely make an issue of it. I think we do also have we've got one young lad, and we've had it in the past where anaphylaxis is an issue for an allergy, and they're really on the ball, and they'll tell you and they'll warn you, and they'll say he's carrying it, he's got it in his bag, he'll have it with him all the time, and you kind of, so you know it's there and you know what to do and you know how to deal with it. It's the asthma thing that bugs me, really, that sometimes we see young people use it as an excuse as well. That frustrates me, and you think either it's an issue or it's not an issue. So kind of like engage with us or don't engage with us. That's the issue, sort of thing, that I really struggle with. Sorry.
It is an interesting cycle though as well, isn't it? Because sometimes people don't join in because their asthma isn't well enough controlled to, and sometimes they use their asthma as an excuse not to join in. And I think this is one of the things that's really important about the inclusivity. And we know that, being overweight and obese gives you a higher disposition to asthma. One child I looked after was amazing. He had really difficult asthma. We were really struggling with them. And one day he decided to join a boxing gym. And I tell you, that changed that child's life. The fact that he got active and exercised, he lost weight. His asthma didn't go away, but it was so much better controlled, and his quality of life was, and he was running 5K and this, and it was just unbelievable to see. And what we need to do is give the children like that and into these activities in a safe and controlled way. Louise.
Thank you. Just to go back, and obviously it's really, really helpful to hear your experience and your background, obviously from Tyneside Outdoors. I think it would be really helpful if you could give us an indication of what it is that you think we need to do to be able to support organisations such as yourself to be able to deliver on that and provide truly inclusive services.
I think because basically it's an outdoors youth club we run, sort of thing. So we're in the park playing games and activities. But I think for most youth workers, I think having the basic knowledge of exactly what asthma is, how to spot the signs, and how to treat this situation. But also I think there's a bit of myth busting as well. In that, if someone there's that kind of the excuse that the young person comes in with, "I've got asthma, I can't do it." Well, no, I'm sure that's not right. But I don't know, and I don't know to what extent it is right, because I'm sure some of it is right, but not to the extent that you can't do anything. You can't engage in this fun activity because you've got asthma. Well, no, because I've seen other young people thoroughly enjoy themselves and then go away and think, "Oh, that was great," and then have a puff of their inhaler and then sit there perfectly fine, sort of thing. So yeah, I think that there is a bit of that kind of myth busting and kind of providing information that it's not to be feared, but it is to be concerned about, sort of thing. The level sort of thing needs to be looked at, I suppose.
And one of the things I would say, just for information, is a child with asthma that's well controlled should pretty much be able to do anything. Now, when I say that, I'm not sure that they might struggle a bit running around today with the cold air, and it might trigger things. But equally, if people are aware of that and they had some preventer beforehand, it shouldn't mean you can't do it. And I think this is what we really need to do. And I see Louise has just put the link to the level 1 training in the chat. That it is really useful, and it gives you a lot of these groundings. And I think the other thing that we need to work on is having that feedback, because I think sometimes parents don't realise how much their asthma is impacting the children, or the children realise that this isn't normal. And what we're hoping to do as well is to empower people to say, "Oh, my understanding is actually you probably should be able to do most things. Is it worth just going to get your asthma checked out, and things like that? So yeah, but no, that's really helpful and really useful and exciting to hear from you, Gerald, because youth workers are such important roles in these children's lives. Louise?
Sorry, I was just going to put it in the chat there. I think it was just worthwhile recognizing that we've also, as part of the development of the resources, we've put some template letters that are available for schools and obviously for sports clubs and groups that could kind of help empower organisations, individuals to kind of flag it when children maybe are needing to use their salbutamol inhalers more, or just to basically improve that kind of communication, really, to help them, push them on their way to get the right treatment and intervention.
Has anybody else in the group come across any particular challenges or any success stories where they've found things that have worked really well to get children involved? No, I think some of it is, though, it's finding that in, isn't it? Finding what appeals to the children. I often joke with the children and young people in clinic that the boys especially tend to fall into two groups, and there's those that are really sporty and are out doing football every night, and then there's the ones that like to exercise their thumbs and their whole social life is spent hooked up to a screen with a microphone. And I guess it's engaging that latter group, isn't it? And how we make the difference. No, has anybody else got anything they want to add to the discussion? Ahmed?
I was really keen to hear if there's any successful stories or any problems, but I just will take the opportunity as part of the leadership group and highlight the resources. We have the Beat Asthma is a very good resource. It has a lot of information on it, how to diagnose, how to treat, and videos, how to use the inhalers. And it has a section for professionals, including primary care and secondary care, and section for the parents and the patients. Healthier Together, we have put a lot of resources there, which include the referral pathway between community and primary care, and primary and secondary and tertiary. There's templates of letters that can be used by different organizations, sports clubs and schools. If you have doubt about diagnosis of asthma, and I think Louise have just shared that, or if you think there's an asthmatic child not well controlled, so please have a look at these resources. It is very useful. It is it has links to different other things, but it's two main websites that we put a lot of resources there that might be helpful if you need any help or support, and we are here.
Thank you, Ahmed. I appreciate people aren't always necessarily comfortable speaking out in big groups online as well. So I think if there's anything in particular that you think as a group we need to be doing, Louise will put an email address in the chat where you can feel free to contact us, or just by the Child Health and Wellbeing Network general email messages can come to us, and we're happy to, because ultimately we all just want the best for the children. Jen, sorry, you've got your hand up.
Yeah, no, it's all right. I was just sitting here with my health inequalities head on and just thinking about some of the difficulties that certain children from different groups of in the population might have different difficulties in managing their condition. So I'm thinking particularly around young children with special educational needs, for example, or children who will physically struggle because of other disabilities, for example, to manage their condition. Is that something that you see very often, and do you have a different approach to managing those children?
So I think it's hard for me to answer this because I'm always aware that I'm very much a tertiary paediatrician, and I've got a huge bank of resources with me. And the interesting thing I find is when we do have the children with disabilities, we can't always use the same resources that I rely on. So, for example, the diagnostic tests that we do every time to clinic, lots of children with disability can't do that, and you have to adapt things. But we had a lot of adaptations. We have different spaces that can help. I guess what is often more complex for those children is they often have additional other underlying reasons for their chest not being as good, and it's teasing out what's what. I think that the biggest group I struggle with are the socially deprived, you know, the poverty, the children who are living in poverty. So they're sharing beds, they're sharing bunk beds, they've got damp on the walls, they've got all these triggers that you can't escape from. And often within these families, there's a lot of chaos as well. We're asking them to take medication regularly twice a day. And a lot of these children don't even brush, you know, you ask them, oh, do you brush your teeth twice a day? And the amount of times that's said no, and it's how you can get life-saving, life-altering medication into children that live in chaos. And I think that's a massive challenge. And I think that's where the kind of social, more public health side of things really important. Carol and Claire, you've got your hands up.
I'd just like to say that one of the things that remains quite concerning, certainly from a clinician's point of view, is the expectation of parents for children very young to take total control of their own medication. So I think there is an expectation, I think, for children to become involved and to understand what the condition is about. But I think it never ceases to amaze me where somebody says, oh, when we ask the question to the parent, how often do you forget your inhaler, or how good are you remembering your inhaler? And the parent looks to the child for an answer. And I personally think, as a parent, I can remember, and I'm lucky I had 3 healthy children. They forgot dinner money. They didn't, you know, they said, have you got your bus pass? Have you got your slip of paper? Have you got the letter that's to go back to school? If I know that I would have had to have been very hot on, have you taken your inhaler every morning and every night, and probably getting them to see that they've actually done it. And the number of expectations that, well, no, I don't see him do it, but I know he does it because he says he does it. But then when you start asking those questions in clinic, you know, when mum says, have you taken your inhaler? Actually, how many times have you actually taken it? And a lot of them say, oh, I don't take it, I just say, yeah. So I think in terms of that, there's a lot of, I think, anticipation, I don't know what the word is really, or expectation that a young person will actually take their inhalers regularly. And we know the expectation, if you read clinical papers, it said we should actually just suspect that people are only 50% concordant most of the time. So, and then if you've got a young person there and you're expecting that 50%, they're probably only 50% of the 50%. So it's not likely that they're taking very much treatment if they're totally left to be independent of their treatment. And it's how we address this, and certainly with the families from the social deprived areas and children of inequality groups, I think they are the most worrying ones in terms of that expectation that they're going to take sole responsibility of their treatment, and that we know that children don't. They've got other priorities, you know, getting your hair right and getting out to the bus on time. That's the priority. It isn't taking an inhaler.
I think that all ties in, Carol, with letting children have a childhood, isn't it? And having a responsible adult who's got the time and the mental capacity to support that. The other thing we see is the not recognising that their inhalers are empty, and even with the inhalers with counters on, them saying, but I can still feel there's something in there. So, you know, I thought I was saving the NHS money. But I think that there is that balance about supervision as well, isn't there? That it's not just making sure they've got it, it's having an awareness when the medication's going to run out, that it can't run out today and you go and order it today. You need to think, oh, I've got 5 days worth left, therefore I need to get it, so we don't have that gap. And I think this is where, you know, the social prescribing and the helping families with this can do. I mean, in some of the worst cases, we've had schools help us with giving medication, but again, there's limits as to what they can do, and schools can't do that for all children. Louise, did you want to come in there?
Thank you. Yes, it was just going back to something that Carol mentioned earlier about, the issue around, the expectation that young children are kind of got some sort of oversight or responsibility for their own medication. But I guess I just wanted to reflect really that it's a bit difficult that, because actually at some point there is the child does need to become independent. And I guess it's how we as a system can kind of build that kind of transition at the most appropriate time for that child, whatever that is. Because it's different, isn't it? And this is, what we found with the schools. The primary schools have got a very, the teachers and the teaching staff and the lunchtime dinner ladies, and they've got a lot more kind of they do a lot more intervention in that sense, helping children, identify when they might need to take an inhaler. Whereas when they get to secondary school, that infrastructure isn't there. And I think for us, we need to kind of build that into our resources. And I guess it's just being mindful, because it's, we're not saying that there needs to be somebody responsible in any given circumstance. It's almost like that needs to be flexible, depending on the family, the situation, the setting, and the whole lot that goes with it.
But it's also the recognition as well, Louise, that you've got there, that it's different for different children. And I think this is the difficulty with the difference between primary and secondary schools. One, there's quite a big difference in age between the youngest and the oldest in a school year, but there's a massive spectrum in maturity and ability to assess risk and things in those. And it is a big step that we do need to try and individualise. But certainly what we do a lot in clinic is you'd start with them taking responsibility for their reliever inhaler, and the kind of preventer inhalers become almost the last thing. So, you start to get them used to, if they need their salbutamol before sport, or having it in their bag, and that responsibility, I guess, like you do with your kids' homework diaries, or getting them to make sure they've got their PE kit and things. Yeah. Has anybody else got any other comments?
We had a young boy, and he was age 8, and I asked him how good he was taking his inhalers, and he said, Alexa reminds me. And I said, oh, is Alexa your sister? And he said, no, Alexa. So he programmed Alexa to say, whatever his name was, Robert, it's 8 o'clock, you need to take your inhaler, and she will. So it's our modern technology times, but I was really impressed with that. We often say to young people, put an alarm on your phone at an obscure time where you think, why have I set that alarm? And then it says, that it sends you a note, you need to take your inhaler. But I think in terms of, there's been a lot of transition work done in the region, and I listened to a very interesting lecturer who talked about the adolescent brain and the fact that, you don't fully take responsibility for some people until they're age 25. But we have this big expectation that somebody's going to make their inhalers a priority age 14, when at age 14 there is so much more importance going on in your life than inhalers. So I think you're right, Sam. I think there's a variability not only between ages but between families as how much responsibility they take for their own. Does mum sort of do everything first thing in the morning and put the school bag out and everything else, or some children are taking responsibility for themselves as young as age 8? And I think that's the difference, isn't it? The personalisation of asthma within clinic is not only done in an asthma management plan, is it? It's done in the dynamics of the family and the capabilities of that family as well.
Yeah, I think one of the things that's really difficult with some of the asthma medication though as well is it doesn't make you instantly feel better. So, we know with your preventer inhalers, it can take between 2 and 6 weeks to have an effect. And that's really hard when you don't get that immediate feedback. And we know with the reliever inhalers, you feel better very quickly. And it's kind of tying with that. And then if you get, my youngest child, we set a bedtime alarm on Alexa for him, and he soon figured out how to turn it off. So it's what children's priorities are, and so on. But I think, we are lucky. We have got a lot of tools out there that can help. And it's interesting, even a lot of very socially deprived children do have smartphones, certainly a lot younger than my children did. So if they choose to engage with them, although there is some shocking statistic about how long a downloaded app is left on a teenager's phone for and how often they use it. I think most apps aren't used or deleted within 3 weeks. So it is about having things that grab their attention and works for that individual child. Okay, so if there's no other comments, I'd like to thank our speakers for the 4 talks. Sorry, Andrew had to go away. As I said, please do, if you've got any questions or comments that you'd like to make outside this forum, please do contact us. And I'll hand back to Louise now, but I think you'll agree that was all a very interesting and stimulating session.
Hi, I think there's just a few slides, isn't there, Jen? So really it was just to round up the session from today. Obviously we've had some really fantastic talks. It's been really interesting, and I'm grateful that we've had the opportunity to also share Ellen Raffles' video. So I'm just going to hand now to Jen, who's my colleague in the network, who will just do short roundup and a bit of information about On the Horizon to kind of promote some of our ongoing work.
Thanks, Louise. Yeah, it was really just an opportunity at the end of the session here to talk a little bit more about Healthier Together, because I've heard it mentioned quite a few times throughout the session this morning, and just to outline what it actually is in case you aren't aware of it, and also the sort of benefits that you might find from making use of it in your own role. So Healthier Together is a website and an accompanying app, which has been locally developed from a model that has been used in other areas of the country. So it's entirely been reviewed with local clinician input, so that all of the pathways and advice on there is relevant to people living in our region. And it's essentially works in the same way as you might look on the NHS website if you wanted to check for symptoms of whatever you were feeling, and then to get some advice on what to do about it. But it's very much focused at parents and carers of especially young children and babies, and it's very much around childhood illness and what should I do? My child is poorly, my child has a rash, my child has a fever, and it guides you through that whole process of looking at what their symptoms are, and then the action that you can take. And the aim of it really is sort of twofold, in that it will help sort of ease that anxiety that parents have when their very young children are poorly, that sometimes makes them think that, oh, well, I better just take them to A&E and then they can help. And it helps them work through the process of, well, maybe they just need a bit of self-care. Maybe you could pop to the pharmacy and get them something. Maybe they just need a GP appointment on Monday. And it's not oh, we must get them seen now. It just helps to manage that anxiety in them, and know that they're doing the right thing. And then it also, on the flip side, reduces that burden on our acute services, especially at this time of year when you've got people turning up at A&E en masse, with children that could really be cared for elsewhere. So it reduces the pressure on the services as well. And there's lots of resources for professionals on there. So in whatever role you're in, there's probably something on there for you. There's resources and tools and different bits of advice on different things, as well as these clinical pathways that professionals can look at as well. Sort of outline quite a lot of this, but it's around the promotion that you can have of Healthier Together in your role. So we're really trying to push this out now over the winter pressures period, so that parents and carers especially are aware of it as a signposting tool. So if you work with families in any capacity, it's here for you to show them how they can access all this advice. There's toolkits available for social media, for newsletters. We can share those with you. There's a link in there if you do get this, get the slides to share, and you can email my colleague Laura for any further information on it. There's posters and graphics that you can use, and there is some printed resources available as well if you actually have the ability to put up posters in a waiting room, for example, or anywhere that families might come across them. This is sort of an example of the sort of information that's on there. This is around bronchiolitis and RSV, which is obviously really important this time of year. You might see more cases of it. So each sort of clinical condition will have a little bit of explanation around it. It's you see they're related to asthma. You can click through coughs and colds, COVID, general difficulty breathing if you don't know what the problem is, and it will sort of lead you through the pathway to find out what to do. And the advice works on this sort of traffic light system. So this is, you'll have green for self-care, amber for pharmacy, GP, any other action that you might take. And then red is when you really have those sort of red flag warning signs in your child's symptoms, and that's when it will direct you to urgent care. So it's not about trying to stop people going to urgent care, it's about making sure the right people go to urgent care, so that if you're seeing any of these red flag symptoms, don't wait. It is very important you get someone to look at them straight away. And then it'll give you some sort of, this is the sort of green advice that you might get, so that it's advice about self-care and more preventative measures and that sort of thing. So there's all sorts of things on here for lots of different conditions and symptoms that young people and children and babies might exhibit. So you can go and have a look at that at your leisure. The apps are available to download on the Google Store and the App Store. So there's versions for whichever device people might have, or there is the website itself, which obviously also works on mobiles if people don't have the app downloaded. So the ask there really, on behalf of Laura, is really pleased just to try and push this out as much as you can. Have a look at it if you haven't been on it yourself previously, and just familiarise yourself with the content that's on there. And if there's anything of interest to you in your role, please do make use of it. That's what it's there for. And contact Laura if you've got any more questions around it. There's information about cost of living resources on there as well that we produced for last winter, which is very much focused on children living in cold homes and that issue with damp and mould, and things that they can do to address that. So it'll advise people on how they can access benefits they might be entitled to, for example, or how they can resolve issues with housing, and it'll direct them to any resources that are available in their local authority area as well. So there's lots on there other than the clinical information. And then just more broadly about the network, you heard Louise give an overview at the beginning of the Child Health and Wellbeing Network and what we do. This is just some of the ways that you can engage with us going forward if the network's new to you. So we'll bang on forever about people joining the network. If you want to become a member, this is how you can make sure that you get all of this information from us. Our weekly Child Health Tuesday email bulletin, newsletters. You can follow us on social media. This is a Huddle we're in now. So we have an ongoing programme of these on lots of different topics on a semi-regular basis. So you might find that there's more of these sessions that are of interest to you. I just wanted to highlight some of the links there to some of the resources that are available when you do get these. So there's the Facts of Life report that Louise mentioned at the start, which is very much about the data around some of the inequalities that we have in our region, which might be of interest to you. The Core 20+5 toolkit for addressing health inequalities is some of my project work with our health inequalities advisors, and that is a toolkit for using the Core 20+5 framework, which is an NHS England devised model, but we've adapted it so that it's more for use for people in community settings, for example, in VCSE, in education. So I'd encourage you to have a look at that if you're interested in what that is all about, and please do get in touch with me. There's information in there that might be of use to you. And then the cost of living resources, which I've just mentioned on the Healthier Together website. If you want to signpost any families that you work with to sources of support, if you see them in clinic and you're concerned about their living circumstances, for example, you can share that resource with them. And Healthier Together is on social media as well. We have campaign toolkits for template tweets, posts, that sort of thing, if you want to make use of those. And here's just some more links that you can follow. The slides are really useful for you, hopefully, when you get them, because you can click around and explore all of these different resources. So please do get in touch. The QR code is there for you to join the network if you want already. And we'd love to keep in touch with you and make sure that you get the full benefit of everything that we can offer. Final comments from Chair. Sam, if you had any more, I think you might have summed up already, but please do. You're welcome to round off session for us. Thank you.
No, thank you everybody for a really enjoyable session. It's been lovely seeing so many network members from the footprint and from the different areas of the network, and we look forward to seeing you in other sessions. Thank you.
Thanks, Sam. Thanks, everyone. I'll stop recording now, Louise. Thank you.
Thank you.
Thank you.
Thanks all.